Thank you very much, John. Let me introduce then another program which is somewhat similar in nature that Jonathan Rabinowitz, who's the Elie Wiesel professor at Bar-Ilan University, concerning the NewMeds collaboration on psychiatry trials.
Jeff, thank you. Thank you very much, and thank you to all of the organizers. I'm going to talk to you about our project called NewMeds, Novel Methods for Development of Drugs in Depression and Schizophrenia. It's a European Union-sponsored project. It's a unique project. It's a private-public partnership. And I'm going to talk to you about our repository of data. And I'd like to just ask you for a moment, with the exception of those who are listening to this as a webinar and operating a motor vehicle, or any of those in the audience who have narcolepsy, just to close your eyes for a second or allow yourselves to imagine what you might do in some therapeutic area that's near and dear to you if you had access to almost all of the data out there in your given area. And just think about that for a second. All right. Because I'm limited on time, it had to be a short second. It couldn't be a full minute. But if you could try the exercise at home, again, not while operating a motor vehicle, it could be very useful. So I'm going to tell you about 2.5 years ago, I was approached by Kshitij Kapoor with some people from the Institute of Psychiatry in London, who was sort of the mastermind and main academic head of the NewMeds effort, and people from industry he was working with to put the project together. And they said to me, would you be willing to take on heading a group that would create repository of data on antipsychotics and antidepressant data and try to mine this data? And I accepted the challenge, and I'm going to tell you about the fruits of our labor and also some of the toil involved in creating this data sets. So these are our partner companies. It's a European Union sponsored event, study under the Innovative Medicines Initiative. So these are the list of our various partners, universities, and SMEs, which I learned stands for Small Business Entities, I believe. Not to be confused with SMSs. Okay, this is the funding and the overall goal. NewMeds has 10 working groups that vary from things like animal models, imaging techniques, and I'm going to speak about the topic of advanced data analysis techniques because I don't know anything about those other topics. So, okay, and I'm going to tell you some of the findings we had. We put together, first of all, these are our methodological accomplishments. Now, I stole the wording from this slide from the Institute of Medicine. I was invited to speak at a CNS forum of the Institute of Medicine a year ago, August, and they had set up for this meeting these objectives. And lo and behold, we had met these objectives, and I'm very proud of it on the methodological level. So we've established a consortium that shares data, and just to use the parlance that was used earlier, this is coded patient participant level data. Is that right, Deborah? Okay. From industry and academia to examine pre-competitive questions. We've overcome challenges associated with establishing data sharing. We pooled and mined data from studies that have sufficient common experimental designs to have reasonable chance of valid conclusions. Okay, we have 2 data sets. This is our Schizophrenia Database of antipsychotic drug trials. These are the companies that contributed their data. These are the pivotal studies and other studies that they had. We focused, what I'm going to present today are the placebo-controlled studies and the lessons that we learned from those studies. We also have 1 NIMH-sponsored study and 1 EU-sponsored study. So altogether, we're talking about data on almost 26,000 patients from 64 industry-sponsored trials and then 2 additional trials. We're also in the process of setting up now our antidepressant database, and this is what we have so far with additional data on its way from Eli Lilly. So far, we've mined the schizophrenia data, and I'm going to talk to you about those lessons today. So I'm going to just jump to our major findings, just that you have a sense about how this might be useful in other areas in which you're involved in. Our first focus was the issue of placebo response, which is a problem in many different areas of medicine. We found, first of all, that studies could be shorter. Most studies were 6-8 weeks. At 4 weeks, you knew what you were going to know later on. We also found out that females showed more pronounced differentiation placebo-active treatment, yet they were underrepresented in the studies, suggesting that possibly if we had more females in the studies, we might show a larger signal. We also found that a group of patients who had later onset of disease showed more pronounced improvements irrespective of their allocation to active treatment or placebo, but it didn't affect the differentiation. However, we did identify a group of patients who were under the age of 30 but had more than 4 years of illness, so they were after that critical first onset of illness group, and they showed a heightened active and placebo difference. We also found that patients that had what's known as both positive prominent and negative symptoms showed the most placebo-active treatment differentiation. And we found that we were also looking, one of the lore of trials was that people who are running trials, because of the desire to recruit or the necessity to meet certain recruitment requirements on a timely basis, were possibly bringing people into the studies who were not eligible for the studies. And we looked specifically to see if there was an overrepresentation of people who were just meeting symptom level criteria. We did not find that those people were overrepresented, which was actually a favorable finding and spoke well of these studies. We also found one of the issues in these kind of populations of patients who are on antipsychotic drugs is use of benzodiazepines. These are people who have active symptoms, and there's a need sometimes to give them benzodiazepines. The question that people had was whether maybe those are being used and showing an antipsychotic-like effect, and maybe they're used more in placebo patients. We did not find that this was the case. We also found that there was more placebo-active difference in Eastern Europe than in North America. Again, this didn't surprise people who were involved, but it did confirm something. Why that is, we don't have the reasons why, but it's an important finding that we were able to confirm. Now, we put all this data together, and then we said, how could we use this in terms of thinking about designing new trials? And we used a technique of resampling bootstrapping, in which we created 1,000 sample trials by drawing patients from the studies that we had from our repository of data. So you will see over here that the current studies, the balance of patients as they are now, which is 70% female, 30% male, 20% early episode, and 40% enriched. Enriched are patients who have both high, prominent, positive, and negative symptoms. That's the current landscape, if you were, of the studies as they are. And those studies required for 90% power, about 79 patients per arm if you were to have a two-arm study. So then we said, okay, what if we use what's called enriched? Enriched are patients who have prominent positive and negative symptoms. So we would restrict the inclusion criteria to those people. Now, we're talking about drug discovery trials, so that I'm not talking about necessarily registration trials. We want to do more efficient drug discovery trials. We want to increase the signal. We want to have shorter trials, less exposure of patients to placebo and experimental treatments that may not be helpful for them. So then we said, okay, what if we just made sure there was equal opportunity of males and females in the studies, 50%, and now you're at the third line over there. So then you were able to reduce sample sizes from 79 to 71. Now, what if you put that together with enriched? So you took 50% female, and then you took only patients who had prominent positive and negative symptoms. Now you're down to 60. Then, if you took patients, half the patients who are early episode, those are the patients who are under 30 but 4 years after their first illness onset, you're down to 57, 53, and so on and so forth, and down to 46 if you used, if you combine the various different elements together. Now, it's quite a savings in terms of patients' exposure, as we said, but it's also a savings in terms of money. Just to give you an idea of currently costs of conducting such trials, okay? Per patient cost for a 6-week study now of an antipsychotic drug is $70,000 to $100,000 per patient. Okay, so imagine if you can save from 79 down to 46, how much money could be saved in addition to saving people from getting exposure to placebo or active treatments that may not be good for them. So, and that's just one illustration of some of the work that we've been able to do with our data set. The other finding that we have is that you could shorten the trials from 6 to 4 weeks, which has implications in terms of exposure and also in terms of how much it costs to do the study. And the less you spend on treatments that aren't going to work, the more money you can spend on developing, new treatments and other trials. Let me talk about some of the implications of our findings on future drug development that I sort of mentioned as I went through this. Trials could be 4 weeks duration, using representative enriched populations and proof of concept trials. We also think here that there's a paradigmatic shift of data sharing as an ethical imperative. We feel that studies should be valued, should be given extra credit in ethical review if they're willing to share data. I can envision, for example, that there'd be institutional review board forums that have a box. If you check it, is the data going to be shared afterwards? If the data is going to be shared afterwards, then one could argue the study has more ethical validity than if the data is not going to be shared afterwards. Oh, what was that? Okay. Okay, let me talk a little bit about, in the 4 minutes and 21 seconds that I have left, there's a clock ticking here, but I did bring a quarter with, I can buy some more time on the meter. So that, talk about some of the facilitators of our effort in getting together within a very short time data sets from fierce competitors in a very competitive business. Well, the companies had united around this external funding of the IMI, which was focusing on this innovative medicines initiative in a time when industry was having a very hard time with developing CNS new drugs, particularly schizophrenia and depression, and companies were leaving. So there was distress that created a common need. There was a recognition by industry that drug discovery was becoming more difficult. And one of the other facilitators was within the companies to have a clear message of support, because it wasn't just enough that the VPs of companies got together in London with us and they agreed to participate, that they needed to give this vision and transmit it within the company. And there's resistance within companies at various levels, and some of them might seem mundane levels of the people who need to go find the data, who can say, oh, well, I have an emergency thing, we have a study report due, we have data for the FDA. There are hundreds of reasons, if anybody's interested, I can give you a few over lunch, why not to cooperate, a low-level person, and find the data and give it. One of the other things that was helpful was previous relationships. I had worked with people in the companies before on various projects, and that goes a long way to fostering the kind of trust that one needs to give over this data, where the understanding is that we're not doing cross-product comparisons, but we're looking at ways of beating placebo. But the data could be misused, and that was something, a trust that we needed to have. Another thing is that we had active collaboration I have a board, my study group, and we all talk together about the various questions, and they share in interpreting and understanding the data and the data results as well. We also had peer pressure among the companies. If one company gave in all their data, the others wanted to follow suit. They didn't want to feel inferior in terms of their performance in this realm, and we certainly use that to the max. There are a few challenges in the minute and a half that I have left. Locating data, it might sound mundane, you know, but locating data sets in companies is very complex. There were companies that were bought, products that were bought by companies and so on and so forth, and to locate who actually houses data was really almost the work of a detective needed to do it. And there's also competing internal resources and priorities. We were not necessarily the first priority, although perhaps because I was the biggest nuisance on the block, I did get the job done. I'm not sure. What's that? Yeah. Yes, indeed. Okay, thank you. Anyway, so these are, let me just talk a little bit about the future with the 41 seconds left, which is part of the future. What if all trials were stored in a uniform way and patient-level data routinely entered into a data bank? I mean, we have almost all the data here on second-generation antipsychotic drugs, and it's really a wonderful data set. Imagine if we could do this routinely. Who's best positioned to do this? Perhaps the regulators are, because they get the data. How does data sharing or unwillingness to share data impact the risk-benefit ratio of conducting a study? Well, I argue that if you're not willing to share your data, your study is inferior ethically than if you are willing to share your data. And finally, I'm at -2 now. Our experience is that the common good can be greatly enhanced by sharing the data. Thank you very much.